Okay, thank you, Teresa. Unless there are any questions, we'll move on to the next item on the agenda, which is MOAC activities, and Deborah has a report for us for that.
Good morning, everybody. Late December and early January, as I'm sure you might imagine, have proven to be a very busy time for the Mohawk position. So the data that you see in the written report was current as of January 3rd. I do have the new data for you that's current as of Monday, January 10th. So just to run through that quickly, our test positivity rate is currently at 8.9%. There is a lag in reporting that, so it's thought to be much higher than that actually. And anecdotally, based on reports from the ED personnel in our meetings, they're seeing much higher test positivity as well. Along with that, there's been a significant decrease in test availability and an increase in test turnaround time, so people are taking much longer to get their results. Our case rate is currently at 47 per 100,000. So that's about as high as we've seen during our previous peaks at this point. As of yesterday, we had 52 COVID positive patients hospitalized, with 10 in ICU and 7 on ventilators. And we've also seen 80% of our eligible population get at least 1 dose of the vaccine, and 71% are fully vaccinated at this point. For genome sequencing, we're currently seeing about 80% of the Omicron variant in the caseload, still about 20% of Delta. Otherwise, we applied for a local optional scope of practice expansion for our paramedics to be able to vaccinate those between the ages of 5 and 12 years old. We are also pursuing a similar LOSOP for our EMTs. We've submitted the request to EMSA. Unfortunately, they have not yet approved that. So we're continuing to reach out to them on a regular basis and pursuing implementing that for our BLS providers. We know that's an important expansion for many of our communities, especially of those down in the South County who may not have ALS providers available to them. We're seeing a huge increase in requests for supplies, testing kits in particular, which unfortunately we're just unable to obtain from the state at this point. There just is not inventory to be had. We're also starting to see some requests for staffing assistance. So that's always of concern when we're not able to staff all our facilities. At this point, those are primarily coming in from our skilled nursing facilities. We've been working on monoclonal antibody and other therapeutics ordering. We've taken over setting up the hospitals to be able to receive that and those therapies, and putting in weekly orders for those. EMSA and CDPH have begun a series of what they're calling medical surge coordination calls. So those are targeted to those 2 groups, along with our regional disaster medical health specialists, Mohawks, LEMSA administrators, and LEMSA medical directors. Those are being held twice weekly, and they're basically sort of a quick situation status update report call. As a part of that, we're being asked to submit data for each of those meetings to our RDMHS for Region 2. I've had to reach out to some of you on this call for assistance with that data. Some of the elements, a lot of it we're able to do independently within our either ESO or CAD or other resources, but we do need your input on some of those. So for those transport agencies and facility representatives on the call, you should have received emails about that. So we do appreciate your assistance with that request. That's all I have for the report at this time, but I'm happy to answer any questions about any of the items or anything else Mohawk related.
Okay, thank you, Deborah. This brings us to our next report, which is ambulance patient offload times. Kimberly Hernandez has a report for us for that.
Thank you, Dr. Burley. Let me just share my screen. Oh, Deborah, can you not share your screen so I can share mine? Thank you. Can everyone see my screen?
Yes.
Thank you. Okay, so in APOT, so we have on the slide August through November. In October and November, APOT, and on the screen right now is the average. In October and November, APOT times throughout all the hospitals stayed relatively stable. You'll see at Natividad, the APOT times evened out a bit after the uptick in August and September. And then I'll show the 90th percentile. We continue to review the APOT data weekly, and we report this information to all the hospitals individually on a weekly basis as well. Any questions?
Okay, thank you, Kimberly. That brings us on to old business. And the first item on the agenda under old business is law enforcement requests related to blood glucose, jail, and medical checks. And Deborah has a report for us for that.
All right, and you should have the agenda packet back up for you, Dr. Burley. So with regards to law enforcement and intoxicated persons, we received several questions from law enforcement representatives related to these items. We have prepared drafts of those responses. Those are currently being reviewed internally and should be ready to send back to law enforcement later this week. That's kind of the status update with those. So still in process.
Okay, thank you, Deborah. And the next item under old business is disposition of intoxicated persons. So you have a report for us for that?
Sorry, I kind of lumped those in together. Same status update for that item as well. Perfect.
And that brings us on to item C, which is the LOSOP blood and blood product transfusion monitoring. If you'd like to give us a report on that.
Yes. This item, we are still working on training development. It's been delayed with progress due to the increased Mohawk activities and our work on the policy and protocol cycle. So as those begin to slow down a little bit, we'll pick this one back up and get it moving forward through the LOSOP process.
Perfect. Thank you, Deborah. And then the next item is item D under old business, which is EMS personnel vaccination status and hospital access.
And Dr. Burley, I don't know if you want to speak to that one instead of me, or I can if you would like. Or
sure. So guys, just an update from our work on this issue. I just wanted to let our stakeholders know that we have continued to look into this and reached out to the public health officer regarding this concern. And at this time, the county is not looking to move forward with a mandatory vaccination for EMS providers. I will say that, as probably most of you are aware, especially working clinically in the emergency department, vaccinations, I think, have been shown to be helpful in limiting the severity of COVID-19 and hospitalizations. As you know, the Omicron variant is the predominant variant at this time. It tends to be less susceptible to the vaccination. And I certainly, from my own clinical standpoint, I'm seeing plenty of folks who have been vaccinated with both vaccines and boosted who are still presenting with COVID. And so I don't know that vaccination is necessarily the panacea in terms of mitigating transmission of the disease that we had necessarily hoped for. Certainly comes with a lot of benefits, and I strongly support it, and as well as the efforts through all of our stakeholders to get citizens vaccinated as well. However, from a clinical standpoint, we are seeing a fair amount of vaccinated folks coming down with COVID and also transmitting COVID. So I think that's just kind of an aside, an observation, and I'm happy to open the item up for further discussion among the group.
It's Michelle Klinsky. I think given the current waiver and emergency status and the fact that COVID infected people are going to be working, this is kind of no longer as relevant as it was months and months ago when we requested it. Again, I think rather than just looking at vaccination, the component of testing was considered an integral part way back when in September and August when this was first being discussed. And now the game has changed, basically. So I guess our request right now would be that, given that you've got a complete waiver to return people to work that are minimally symptomatic with active COVID, that you guys are just fully compliant when you enter our facility in N95s, and that's the standard practice. So we can try to do as best protection as we can in the critical situation we have. That would be my advice.
Nicholas has his hand up.
Yeah. So I just want to make sure that we realize that if you're vaccinated, it does decrease the risk of you contracting this by 50% or 66%. So it still causes less transmission. And I wouldn't, if your workforce is vaccinated, it should have significantly less Omicron disease, although not zero.
Dr.
Yes.
Burley, this is Chief Nieto too. I just want to let the board know, and I'm not taking sides on anything. The rules are the rules, whatever those are. But I did want to report that a preliminary report on line of duty deaths for officers just came out recently, and the leading cause of death was COVID for officers. And there was actually 301 line of duty deaths due to COVID last year in 2021.
Yeah, and 5,000 healthcare workers supposedly acquired on the job in the United States.
So I do have one more question, just with CDPH and requiring healthcare affiliated workers to be boosted or basically not working starting February 1. Where does the EMS fit in that definition of a healthcare workforce? Because I'll be honest with you, folks like AMR, that's all they do is healthcare. And how are they an exception to the state healthcare workforce requirements?
Thank you, Dr. Kalinsky. So, yeah, as far as the state addressing this issue, they have made the determination that EMS does not necessarily fall under the healthcare workers, and whether we all agree with that or not, the state has taken that position. I certainly acknowledge all of your points. I think this remains a highly concerning pandemic. We're far from at a point where we can relax on our masking and all of the due diligence that I think we all need to take to reduce transmission, not just at work but in our private lives. Vaccinations are a big part of that. We support vaccination efforts, as is demonstrated through the LOSOP applications, and we certainly support hospitals mandating masking of EMS providers when they enter the facility. I think that's huge. And so, but as you pointed out, currently there's been a determination to allow even COVID-19 positive healthcare workers to resume working in the workplace so long as they're minimally symptomatic. And given kind of the changing direction there, I kind of agree that this issue is probably a moot point in terms of January 2022.
Chief Craddock has his hand up, and so does Michelle Kalinsky.
Yes. Go ahead, Steve. Dave.
Yeah, I just had a quick question for the doctors, mostly about the hospitals with the N95 mask. I just want to make sure that I'm correct. Is that for the non-vaccinated employees, or do you want to see all of our employees in N95 masks every time they come into the hospital? Because I just want to make sure I understand your intent correctly so we can disseminate that to our people.
So I think from my perspective, with the new guidelines allowing COVID infected individuals to work, because there's so many of us now, right? I mean, this is ranging anywhere between 4 and 20% of workforces. There's no way for me to screen, oh, you were COVID positive 3 days ago, you were COVID positive 7 days ago, you were COVID positive 11 days ago. And at this point, for protection, there's so much positivity. I think that anybody in an emergency service really should be an extended use N95. It's throughout all of the facilities. It's mandated for our workforce, including our registration staff. And I would think as a medical director, this may be something that could be implemented to improve and enhance both workforce safety as well as the safety of hospitals and their patients and clientele. So I would advocate that perhaps a statement come out from you, Dr. Burley, that says, look, we can't comply with the testing, we can't comply with this, but because we're returning positive people into the workforce and we can't screen who's doing what, just let's do universal N95. I don't know how other people feel about it, but I think it would be the safest. It basically, when you're in an N95, you aren't spreading this as much, right? It's both protective from you getting the illness. It also prevents you from spreading it to others. So that's the point.
Mhm.
Thank you, Dr. Kalinsky. Any other comments on that specific point?
Tiffany Wallace.
Yeah, this is Tiffany Wallace from Me Memorial. I was just gonna agree with the doctor who just spoke. We did, I think it was last week, Dr. Hawthorne and I created a memo and sent it out. So at Me Memorial, we've been in all clinical areas, all staff, whether you're clinical or not, if you're in a clinical area, we're asking them to wear N95s.
Thank you. Any other comments?
Yeah, hi, this is Christy Sobleski. I would just also like to reinforce what Tiffany and Dr. Kalinsky said, because we're also seeing a lot of asymptomatic positives. So if these medics, EMTs, and firefighters are asymptomatic, they're not going to get tested and they could still be positive. So I just think a standard of all N95s would be preferable.
Thank you. And I agree wholeheartedly with the comments that have been made. We're at a point where, this is as frustrating and difficult as it is. It's sort of a changing, constantly evolving and changing approach to the pandemic. And we have to take each moment where we're at. And I think in this moment in the pandemic, probably the safest thing for EMS personnel and for hospital personnel and our patients is to make sure that we're appropriately masked. And we do know that N95s are superior to surgical masks or cloth masks or other masks that are out there. And I agree with the idea of mandating that for EMS workers, especially when they're bringing patients into the emergency department to try to maximize the safety of everyone involved. So I'm happy to put out a memo to that extent. And I appreciate your comments.
Dr. Burley, it's Deborah. If I could just add in that if there are any agencies on the call in need of assistance with N95 masks, please reach out to the Mohawk and we can help you with that.
Thank you, Deborah. Any other comments or questions, concerns regarding this specific item under old business? Okay, thank you all. Appreciate your input, and we'll continue to move forward the best we can in the face of the evolving pandemic. The next item on the agenda under old business is 2022 policy protocol cycle, and Steve Brooks has a report for us on that.
Well, good morning, everybody. Thank you for being here, and this can be quite a long topic, so I'm going to move quickly, but if you have questions or comments, of course, we would like to have your participation so we can make sure that this policy cycle ends up with what we desire our EMS system to be and how we would like it to function. So please excuse me if I seem like I'm moving quickly. There could probably a lot of material to cover. I'm sure you guys want to see a lot of the things and at least ask questions. So ultimately, what we're looking for today is for your comments, your questions, your concerns, so we can make any final adjustments to our policy and protocol cycle before we bring it back to this body for endorsement at the March MAC meeting. And with that, I would like to share my screen and we'll go over the public comments and the EMS agency responses to the public comments. And as we do this, if you would like to see any of the policies in particular, more than happy to do that. So I'm assuming you can see my screen with the public comments and the EMS agency responses.
Yes.
Yes.
Perfect, thank you. Okay, so just a little bit of clarity, some comments for clarity. We did, as you hopefully looked at this in your meeting packet, you found that this document is color coded, and over here these color codes represent just a key which we have here for how much work was actually done in these policies. So anything that is green there's no revision. It's the same policy. We found that there was nothing that needed to be updated, and therefore we didn't make any changes. If it's blue, we've made some minor changes. Most of those are administrative changes to some degree, but there's really no change to policy direction. If you see a yellow highlight over here, there is some minor format changes and maybe a minor change to the policy and what we are communicating through the policy. If you see orange, then we've made some fairly major changes, most of it to the format, and then there may be some policy direction change also. Additional information, things like that. Anything that's red is definitely a significant change where we've added a new policy. We may have deleted significant information, but in general, it's created a change to our policy intent and what is expected to come from following that policy. So what I'm going to do is go through the ones that have comments and the EMS agency response. And if you have any questions about the agency response or the comments, please let us know. I'll do my best to pay attention if you raise your hand. So anyways, policy 1000, which is our policy and procedure development. The comment was basically that we should have longer than 30 days for the public comment period. And we as an EMS agency wholeheartedly agree, as Teresa mentioned earlier, we truly want a lot of public participation, stakeholder participation. And so we are looking to extend the period. This period, we tried to keep it away from the Christmas holiday. And so it wasn't as long as maybe it has been, but we thought it was better to have it not over the Christmas and New Year's holidays. So policy 110, which is our authority for this, there's a question as to why the policy was needed. And ultimately what it is the policy that states what our authority is for making the policies, adjusting the policies, leading the system. And so we're moving the authorities that are cited within each policy into this particular policy. Policy 2030, which is the public safety scope of practice. There's two questions from different individuals. One is, what do we do about first aid? But we also found that what they're really asking is does this policy apply to mutual aid assignments where people come into Monterey County to provide service under mutual aid? And it does not. This is a policy only for Monterey County based providers. People who come in from mutual aid come in under their policies and protocols from the sending jurisdiction. Next page. We received nothing on 2060, and I won't mention the ones that we don't have comments on. But 2061, which is EMT expanded scope, there's a question as to why the use of paralaryngeal airway was there, and we agree that it should be supraglottic airway, so we've updated for that. Tactical medicine policy, shouldn't we be using post guidelines? And we believe that we should, include post as part of our policy. So we've done that. Policy 2200, paramedic training program approval. You can see we made some significant updates. This was necessary in that we hadn't updated the policy in a long time. The state regulations were changed, and also some best practices needed to be included in the policy. So we have significantly updated this policy. Specific questions. Is there fees for the paramedic program? We have not established fees for paramedic training programs as of yet. That will be coming. They ask about the EMS agency point of contact, and just to make it easier, any correspondence should be addressed to the EMS agency, and we will disseminate it to the appropriate staff person. Has an actual application been created, and we are working on an application. I believe that has been completed. And before we get any further requests for paramedic training programs in the county. Also, they asked for what the criteria for acceptance or denial of the application. And while we believe the information is within the policy and the regulations, we will be creating a checklist of criteria to both make it easier for us as the agency to review the application and the applicant and all the components of the paramedic program, but also for use by the paramedic training program applicant to be able to easily determine what items they need to do and have in place so that they can have a successful application process. Policy 2211, EMT expanded scope training program. We removed the paralaryngeal airway or the supraglottic airway from that scope of practice. There's a question as to why we did so. And I'm sorry, it was epinephrine auto-injector is what was removed. And the epinephrine auto-injector is now part of the basic EMT scope of practice. So there's no need to have it within the EMT expanded scope of practice. Moving on to the next page. Pre-hospital consent, 4030. A lot of questions and specificity as far as ultimately, we want the policy to allow for base contact if a patient in need of transport, in need of further medical care, refuses the care, refuses the transport, and yet also not mandate that every time somebody refuses that the base contact is required, or even to hint that base contact is a preferred activity for a person who chooses to not either accept medical care or transport. So we agree that there should be minimal base contact for a patient who chooses to not either accept medical care or transport. This is an option if the base hospital can assist with getting the patient to go along with what's best, what is believed to be in their best interest. And that's really it. So we've worked on adjusting the language of the policy to decrease any thought that base contact is a required item or even a desirable thing. And I see Dr. Kolinsky, please.
Oh, do you have a copy of the new language that you can provide?
Yes, give me a moment. I'm going to scroll down here to find that one. Pardon me while I scroll fast. Here we go. So some of the things that we've done is we tried to simplify the language, the procedure, to be just when it impacts the decision-making process, and not just to call to say, hey, we want to cover ourselves because we've talked to the base physician. That really doesn't do anything. It's just to consult whether it may impact the decision-making and patient care process. And as we develop the training tools for this, this is something that we will be highlighting. And then we also pardon me as I scroll down quickly. Oops, pardon me, I missed. In the checklist, we've eliminated base hospital contact as a checklist item because we felt that it was directing people to actually make base contact when that wasn't the intent. So those are a couple things that we've done.
Thanks. I think it definitely looks better, and we'll just see where things go with it. Our goal and hope is that when they call, they want us directly talking to the patient. There's some direct question that people are asking that we need to be there to answer, and not just the heads up, hey, I'm letting this person go. So hopefully it helps.
That is the intent, and we'll be wanting feedback from the hospitals to see if this has helped decrease the unnecessary base contact, and so we can do what we can to not have the physicians and nursing staff interrupted in their day unnecessarily. Okay, continuing on.
Dr. Orchard has his hand up.
Oh, yes, Dr. Orchard, please.
Yeah, hi. Hey, I appreciate that changes. When do these policies take effect?
July 1.
Okay, perfect. Thank you.
That allows time for the training to materials to be disseminated, and then the organizations to provide that training to their people.
Okay, perfect. Thank you.
You're welcome. So we had a comment about extremis, that it should contain uncontrolled airway within the EMS aircraft operations policy. And so we're working very strongly to standardize the language as to what is considered extremis, maybe even getting away from some of that term, and just specifically that if there's an uncontrolled airway, the patient needs to go to the closest hospital. Policy 4120, end of life care. We had language that we agree looked like other documents that may be older, had the same weight for determining what care would be provided to somebody at end of life opportunities. And we agree that the language needed to be changed so that the POLST is the controlling document, and that other documents are used to help in understanding the patient's wishes, but ultimately the POLST is, and the DNR and durable power of attorney are the primary documents. So we've made those changes to make it more clear that advanced directives are not at equal weighting and should be considered with the POLST. Cpap, a lot of question on Cpap related to whether it truly should be discontinued in the presence of a COVID related shortness of breath. And the EMS agency response, which I don't want to go through because it's quite lengthy, hopefully you've read it, is ultimately Cpap for COVID related shortness of breath has really no impact. It impacts other things like congestive heart failure, but not the shortness of breath related to COVID, and therefore should not be used for COVID, and definitely should not be continued as we enter the hospital with COVID positive patients to help prevent disease transmission. It's fairly lengthy, so I'm going to ask if Dr. Burley, would you like to add any comments to that?
I don't have any specific comments, Steve, other than what I've placed in our comments to the public comments. If anyone has any specific questions, I'm happy to answer them.
Okay, thank you. All right, so as you can see, the comments are fairly lengthy. And then as we get down to policy 4511 related to the vascular assist device, mechanical circulatory support devices, and the call to the base hospital, of course, should include any information regarding the implant center so that the base hospital can contact the implant center and the patient's coordinator for information about the patient. And our policy does have that already in it. Policy 5000, patient destination, and it asks about diversion for disaster, and we will be, we've adjusted the language to clarify that non-trauma patients and extremis do go to the closest, and trauma patients truly are best served at the trauma center, even if they look to be, in grave peril. They should go to the trauma center because, let's face it, the local hospitals, good as they are don't have the resources immediately available as the trauma center does to deal with a trauma patient. And so they should just go to the trauma center. Next, we have policy 7001, which relates to special event and medical plan review and how this will be regulated. And ultimately, the plan review is, we're just an adjunct for the process through the RMA, the Resource Management Agency of the county. They're the ones who authorize events, and we just provide guidance, to the organizer of the event as far as what medical services, first aid services are ideal for their event. And I see Dave, you have a hand.
Yeah, I just had a quick question / comment about the approval for the special events. I know there's been a lot of changes at Laguna Seca, and we all want to try and accommodate those. But one of the things I noticed on a recent event where there was a fairly significant pre-event medical plan, most of the positions were to be determined and the RMA approved it. I'd like, if we're going to have that go through the EMS agency, that we try and connect the dots so that if we're going to review plans through the county, that we actually have bodies in those positions and not just a to be determined medical director for an event. Because it facilitates our conversations and discussions with those people when their events come through. That's something that we're going to work through on our end because we have participation in that as well. But it just feels like when we're all on the same team working together, it's a lot easier to get that done. So I just wanted to ask that since it came up for discussion.
Great, thank you, Dave. We'll see how we can integrate that better into our process. Okay, continuing on. Policy or the protocol C3, which is the chest pain suspected cardiac origin, and it's related to the routine administration of oxygen, which we've updated to better indicate that in the presence of cardiac chest pain, oxygen should be limited or not provided if their O2 sat is greater than 95%, or if there's some other reason that the patient would need oxygen. So we agree with that comment. For M1 nausea and vomiting management, question is whether we stock the oral dissolving tablets, and then if we do, then it shouldn't be listed as a PO medication. And so we have updated the policy or the protocol to more adequately reflect that it's an oral dissolving tablet rather than an orally administered medication. M4 sepsis, there's a question as whether we should talk about transmissible by airborne route, and we have actually updated to include information about airborne disease transmission and how to manage that. Then just a comment for 01, which is actually now 02. which is obstetric emergencies, and we do have mag sulfate in there for eclampsia. CP1, which is the pediatric cardiac arrest asystole PEA, and the comments have to do with the termination of CPR, and that our criteria in the draft that was sent for public comment seemed fairly complex, difficult to follow. And we agree that it was complex, and we have simplified the language. And if you have read our response, you can see that we've simplified the language quite a bit, and provide very specific directions to when to maybe consider termination of pediatric cardiac arrest in the field, and definitely make base contact before that is done. Moving on, policy 4509, spinal motion restriction, requesting a language change related to evidence of alcohol and drug intoxication, to impairment, to be consistent with the algorithm. And we've ensured that the language is consistent between the policy written language and the algorithm that's included in the policy. There's a question as to whether the Glasgow Coma Scale can be 15 versus greater than 14. And the issue is that the track changes format makes it hard to see that it's actually greater than or equal to 14. And so that language has remained. There's a question about age of patients over the age of 65 and the rules that we follow when we omit spinal mobilization or modify it in some way. And perhaps we should be more conservative with the patients over the age of 65. And we do address this, that we should use extreme caution for patients over the age of 65, and adjust what we do for the patient accordingly. Then in 4 and 5, we maybe should simplify the language, was the comment, and enhance the notes section. And so we've made some changes within the notes section, changed A to focal neurologic deficits, and tried to make that much more clear for the algorithm in the process of determining what spinal mobilization should be provided, or at least spinal motion restriction, to use the appropriate term. And then comment about starting the chart to go through the pathway criteria outlined, including the age issues, and then we'll review that and have made adjustments. For policy 4501, the Aed guidelines, this is for the public access defibrillator that the state statutes require that we are involved in the process of knowing when an AED is placed out for public use. So the question is, what about the application process? Oh, I'm sorry, excuse me. This one AED guidelines is for basically BLS, public BLS access to AEDs. And ultimately, all our BLS agencies are AED approved, whether they're first responder or EMT, according to Title 22. We years ago approved everybody. So this is kind of a legacy policy. And we agree that it may be a little out of date, but there isn't anybody who's going to need this to apply to be a AED provider at the BLS level. And so we'll be looking at this in the future, but with all the things going on, there's any need to update it. It works as it is. Let's see. So for policy 6020, unusual occurrence reporting, The question is as to what needs to be communicated when an unusual occurrence is reported. There are some things that are confidential, and maybe the provider organization would like to keep those outside of the written unusual occurrence report, and so we have adjusted the language of the policy so that there's a little bit more flexibility in there, but yet the EMS agency still gets the information we need to understand what happens so we can ensure proper management of the EMS system. Protocol N1, chemical sedation, procedural sedation, and there's a question as to whether physical restraints should be part of the protocol, and we will include language that physical restraints should be used when there's appropriate conditions and chemical restraint is also being applied, or sedation in this case is being provided. Nothing on that page, and that ends the public comments. So related to the public comments or any of the policies or protocols that were addressed in that, are there any questions or comments?
Hey, Steve, this is Scott. I want to thank you guys for the process you've gone through. The implementation of getting better public input has been really helpful. As we go through all these policies repeatedly, the transparency makes it easier for our personnel to really grasp it and hopefully maintain a comprehensive understanding of these things that evolve all the time.
Well, thank you. And I will piggyback on that, what Scott, you just said, in that we have really tried to expand the opportunities for engagement with the EMS agency. We've held, granted the regular public comment period, but we also brought the public comments and the EMS agency responses to our TQuick and CQI tag groups for their involvement and engagement. We had open public comment meetings by Zoom where anybody who wanted to could drop in and ask questions about the policies, about the protocols, the public comment process. And for the first time doing it, we seem to have a decent response. We emailed all of our paramedics and EMTs to let them know about the meetings. We posted on Facebook, on our website, and we had people who were typically not the usual suspects, if you will, for being engaged in the process. We had other people show up, and we were definitely looking to continue and expand that for the future policy and protocol cycles. So, probably while I scroll up. I don't think I brought it. Anyways, I did want to, let me take a look here.
Steve, if I can just interrupt for a moment.
Yes.
I'm gonna need to come off the call in a few minutes here. And I was hoping that perhaps Chief Nieto can continue as a stand-in chair during the remainder of the meeting.
Tina?
Yeah, I'm here.
Can you take over as chair for this meeting?
What number were we on?
We're almost done, Tina. But I'm just concerned that I may end up dropping off, so I wanted to do it formally until that before that happens.
Okay, just give me the number we were at. I was just listening to all the reports and.
Sure, Deborah can pull up the agenda and give you the next item.
Once Steve is done with the policy and protocol item, we'll be moving on to new business. So.
Okay, got it. Yeah, I have the agenda up. I just was listening to all the policies, so.
Thank you, and I'll listen in until I need to get off, but it'll probably be within the next few minutes.
Okay. So pardon me while I scroll down quickly. Actually, I'm going to do this differently. Pardon me while I do this. I would like to highlight a couple of policies, and these are the ones that have either are brand new or have had significant revision, just so you can see what we're talking about if you haven't had a chance to look carefully at this. So here's the paramedic training program approval policy. You'll notice that we've eliminated the authority out of the usual section. We've added, significant amount of language as to who's eligible to be a paramedic training provider and the requirements that are needed. And almost all of this is a rehash of what's in Title 22, as well as what is what I've found to be best practices as we've gone through and looked at what other LEMSs are doing and requiring for paramedic program approval. We've taken the best practices and included them, especially here in the procedure section. So you can see we've completely revised the procedure section because, there's approvals that we didn't have in our prior policy that are now required as part of a paramedic training program. So pardon me while I scroll down here. We needed a section about, approval, denial, withdrawal, and negative action. So you can see we've made significant changes to that policy. Policy 4504, drowning, near drowning. This was a policy that we created years ago and kind of mixed policy and protocol together. So we've eliminated a lot of the general knowledge to be much more specific what to do here in Monterey County. And then we also kind of created the policy to when to begin CPR, when may CPR not be begun. And we've used a lot of information from the National EMS policy and protocol guidance put out by NHTSA. So we've included some of that language here. And then what was pretty much a protocol within the policy, we took that out. As you can see, that's all treatment stuff. And we've then recreated a new protocol related to drowning and near drowning, which is this one. And so it reflects the policy guidance as to when to begin resuscitation, and then created an algorithm format for the protocol. So those are the examples of the major policy and protocol changes. Any questions or comments? At this point, I would open it up if you have a comment, question, because again, we are looking at the March MAC to bring these policies and protocols to MAC for final endorsement. So if there's any questions or comments, we'd love to address them now so that we can have everything ready to go to your satisfaction for endorsement in March. So I can talk about it, any particular policy or protocol that you might have a question about, or if you're not sure at this point, please reach out to EMS agency staff and let us know as early as possible, as you review the policies and protocol drafts, so that we can make sure that everything is ready to go for the March meeting.
Hey, Steve, it's Devin.
Yeah, Devin.
Hey, a quick thing. I noticed on the minimum stock policy, you have ketamine as a certain dosage. I don't know if we can maybe look at changing that requirement to the 500 because Nephron has ketamine in a lower dose concentration where we don't have to waste 400 milligrams of ketamine. But your minimum stock policy states that you need the 500 milligram vial.
Correct. And so I think we should have that discussion offline so we can work with Dr. Burley on this. The reason we specified the concentration was this particular concentration would make drug calculation easier. And at the time we could find no manufacturer that provided a lesser amount of ketamine. And if you found one, we can certainly work to adjust the stock levels so that we can not have a lot of excess ketamine that gets wasted and potentially diverted.
Yeah, Nephron has a product 50 milligrams per 1 mil.
Oh, that's fabulous. Let's connect offline if that's okay, and we'll figure out how we can introduce that into the policy and make it easier for everybody.
Dr. Greenson has his hand up.
Yes, Dr. Greenson.
Thank you. So regarding the drowning algorithm you just put up,
yes,
I think perhaps should be a little clarification, like diving injury, like scuba diving, and diving injury, like I fell and hit my head and have a cervical spine fracture. Because I think you're asking, is there scuba diving injury or like a pulmonary overpressure injury on that third box? But maybe that should just be a little bit clarified.
Right, and so right here that we do assess for spinal injury.
So in the next box where you're saying diving injury, I don't understand what that means, is what I'm getting at.
Okay, so that would be a scuba diving, and probably we should say scuba.
Right, because it's different than I dive in the water and hit my head.
Correct. That's a good point. Thank you. We should make that update. Anyone else with comments or questions specific to the policies or protocols? With that, I'll finish up by as we provided earlier in the process timeline for the major milestones as we're moving through this process. And we have said, as always, that the timeline may be adjusted as needed. We have done adjustments. We've extended the public comment period by a week. We added additional Zoom meeting comment period, comment times in here back in December. Where we're at now is at MAC review of the comments, which we've completed, and the EMS agency will be finalizing the drafts and creating the training materials. And by February, we will have the training materials out for review and comments, so that by the time we reach the March 9 MAC meeting, we will have what we believe is a solid package for endorsement, which will be released in April for training purposes, and then in June we will finalize with signatures and dates and post to the website and distribute for a July 1 start date. And that's our timeline. Any questions on the timeline or anything else as part of this presentation? Well, I thank you all for your participation and comments, and we will integrate, especially the scuba diving, into the drowning, near drowning. And at this point, I think I'm done. So thank you very much.
Thank you, Steve.
Thank
I
you.
still see Dr. Burley, or no, he's still logged on, but with that, we'll just move on to new business. Deborah, regarding AB 361.
Yes, so AB 361 does require us to reconsider the particular findings to continue remote meetings on an at least a 30-day cycle. So I know we just discussed this within about a week or so. However, reconsidering this question at this meeting will allow us to only hold one meeting between this meeting and the March MAC meeting, the regularly scheduled one. So we are just asking the group to reconsider whether we should continue the remote meetings based on the requirements outlined in the agenda packet.
So the governor's extended the emergency to the end of March, I believe. That came out about 3 days ago. And I know a lot of people are going back to remote meetings as a result of that. So I open it up for discussion. And I don't see any. Jeff?
Yeah, no, sorry. No discussion points. I'll just make a motion that we continue with the remote option for meetings under AB 361.
I'll second it.
All right, so Jeff Horner made the motion, Deborah seconded it. All those in favor, oh, we got to take a thing. So Deborah?
I'm sorry, I missed who the second came from.
That was for me, Nicholas Greenson.
Got it. Thank you, Dr. Greenson. And for a roll call, Dr. Kalinsky?
Aye.
Dr. Hawthorne? I know he had a clinical shift. He may have dropped off the call. Dr. Orchard?
Aye.
Dr. Greenson?
Sorry, I couldn't find the mute button.
No problem. Thank you. Christy Soboleski?
Aye.
Tiffany Wallace?
Aye.
Cassie Caldera? All right, we may have lost Cassie along the way. Dave Craddock?
Aye.
Scott Houchin?
Aye.
Will Hiller?
Aye.
Jeff Horner?
Aye.
And Tina Nieto?
Aye. That motion passes.
Sorry, I was on a phone call with Cassie Caldera. Aye.
Thanks, Cassie.
Thank you, Cassie. All right, moving on to the next special meeting date. I guess you guys are recommending February 9th.
That's correct. That will put us at the timing for, like I was mentioning earlier, just having the one meeting between now and our next regularly scheduled meeting on March 9th.
So do I need a motion? It shows as an action. So do I need a motion on that, Deborah?
I think if everybody's in agreement, we can just move ahead with getting that out for the next. I don't think we need a formal motion to do that. I probably shouldn't have listed that as an action item. Just looking for any significant conflicts with that to make sure we have a quorum for that meeting.
That's going to be a quick one, right, Deborah?
Yes, that'll be somewhere. I think our last one was 6 minutes. So.
All right, because I know that the Cal Chiefs, that's their conference, but we can call in remotely. So.
Okay.
Tina and Deborah, also, can you just note that I'm on the call. This is Jeremy for representing SVMH.
Oh, gotcha. Thank you, Jeremy.
Mm-hmm.
Thank you, Jeremy. All right, moving on to the Continuous Quality Improvement Technical Advisory Group. Deborah, it's a report.
Yes. So as you can imagine from the presentation that Steve provided, a significant portion of our time and attention has been devoted to the 2022 policy and protocol cycle and all the efforts to communicate the changes and actually work on the drafts and that sort of thing. So that's corresponded to some of the QI groups also being significantly involved in that, and that filling up a bit of their committee time as well. So those were really the focus of the TQIC and CQI tag meetings themselves that we held in December. We did an extensive review of the drafts with those groups, as there were a significant number of changes to the trauma protocols and then just more of a general review with the CQI tag group. The stroke and STEMI groups also met in December as well. We are moving forward with, we have published the 2022 schedule for the QI committees. There have been some changes to the meeting dates. with Steve and I sharing responsibilities for the QI committees, we've divided them up a bit so that each one of us has a committee meeting on the same day. So we're not both preparing for 2 meetings on individual occasions. We've also increased the frequency of CQI tag meetings. There's been a lot of really good quality work done within that group and a lot of plans for the coming year. So we're lining that to meet a couple weeks before MAC, so to help us prepare for the MAC meetings in particular. Those schedules have been published and they are out to all of the committee members along with the invitations. We have been working with the American Heart Association to put an agreement in place that will allow us automated access to stroke and STEMI data from our stroke and STEMI centers in the county. That was scheduled to go before the Board of Supervisors yesterday. Unfortunately, there was an error with the creation of the board agenda packet, and the actual agreement itself did not make it into the packet, so that's been pushed to the January 25th meeting for their consideration there. That's going to really help us streamline our processes and decrease some of the burden of the hospitals needing to put together that data for us. So we're looking forward to getting that in place. Another big thing that we worked on during December, early January was the health data exchange items. So we held 2 meetings with representatives from ESO, one also with representatives from Natividad, and another one with representatives from Me Memorial Hospital. We discussed modifying what's currently going on at Natividad to expand the data that they're sharing with the EMS agencies, and then to implement a process at Me for them to begin sharing their data. So both of those meetings went well and are moving forward through the implementation process. We're basically in a queue at this point with other agencies from throughout the area. So as soon as we can get assistance from their technical staff to begin working on that, we'll continue moving forward with those 2 items. We held a continuing education class. Dr. Burley hosted that. It was on trauma case studies. That was very well attended. We were happy to see that. We made some changes to the way we publicize that class out to the community by emailing all the EMTs and paramedics individually, as well as distributing it to the agencies. A video of our classes are now available on the training page of the EMS agency's website. So anybody that wants to refer to those in the future can see them there. We also recently closed our survey on input on future continuing education offerings. So we'll be resuming those classes in 2022 and using the input that we received to move forward with the class selections and how we're hosting the classes. Finally, the last item is that Dr. Burley has put together a draft training course for base hospital physicians. So our plan is to review that at the next CQI tag meeting so that the group can provide any input it may have. And that meeting, along with the stroke meeting, is scheduled for February 23rd. And the next STEMI and TQIC meetings will take place on February 1st. So that is all I have for CQI tag, unless anybody has any questions on any of the items.
Anybody have any questions for Deborah? I don't see any, Deborah. So moving on to, thank you for that. Future agenda items, anything? Deborah, I see no hands. Announcements for the good of the order. And I don't see any hands or anybody speaking up. So our next meeting date will be February 9th at 9:15. It's going to be remotely, and I know that Steve and Deborah will send out the information accordingly. With that, can I have a motion for adjournment?
Motion to adjourn.
Dr. Orchard, thank you. A second?
Second. Jeremy seconds.
I heard
Jeremy.
2 seconds.
I
Jeremy.
think it was Jeremy and Dr. Greenson, it sounded like.
All right, with that, we're adjourned. So I'll see everybody on February 9th. And our next meeting, well, it's not this, I'll see everybody on the next meeting in about a half hour. So have a good day, everybody.
Thank you all.
Thank you.
Thank you all.
Good day.
Thank
Thanks.
you.